Okay, so I decided to make another video because of something that came up last week, and this is probably for both resident and medical student, and it's on how to prepare yourself for the operating room. On a side note, I would like to say that I saw that my previous video was downloaded heavily, and I think that's cool, and you guys did a great job presenting patients. So I can see that it definitely did help you. So it's giving me an incentive to continue. So how to prep yourself for the operating room. And the first thing to know is what procedure is going to be done. And I hope that the chief resident or the senior resident on the service gave you an assignment or assign you to a room. And if they haven't, excuse me, do not hesitate to tell the attending this was a last-minute assignment, you didn't have time to prepare. I think we can all understand that. Ideally, you should ask the chief resident, and if they don't assign you or are not receptive, come and talk to me. So I think we can divide the preparation process in 3 steps. The first one would be the anatomy. Excuse me. The anatomy. You need to have some knowledge of the anatomy, and I will go in detail about this in a few minutes. Second, what are the indications for the interventions? And third, what are the complications? And that should cover pretty much the knowledge you need to have for the operating room. And I think knowing this allowed to read with a purpose, because you will look for that information in your reading, and I think that's going to help you get organized. So the first question is, where is the incision? I mean, that's true especially for senior resident and chief resident. So know your external anatomy. I don't think there's a huge amount of landmark and to know. I've drawn a quick skeleton here, and the important one, I think, for general surgery and vascular surgery would be the sternum. Sorry, I apologize. The sternum, right? You know where that is. Sternal notch, xiphoid process, and that's, what is that? The umbilicus. Those are the midline landmark, and the symphysis pubis. So this is important. So if you're going to do an upper abdominal incision, what is meant by an upper abdominal incision is usually from the xiphoid process around the belly button and 1 to 2 centimeters below. If you make a full abdominal incision, it'll be from the xiphoid process all the way to the symphysis pubis. Following this, the other type incision would be, the subcostal incision, so the costal margin, important landmark. The 12th rib, which can be felt from the side of the patient. Anterior superior iliac spine, this is especially important in vascular surgery, because if I draw a curved line from the symphysis pubis to the superior iliac spine, I know where the inguinal ligament is. If I know that, I know where the artery is. I divide this in third, and usually between the middle the middle third and the medial third is the artery. So if you expose a femoral artery and the patient has an iliac occlusion, you cannot feel a pulse, but you know that's where the vessel should be. Also, if I know where the superior iliac spine is and the condyles, I know where the sartorius is. Again, this helps me make my incision. So those are basic things I think that can be very helpful, and please know, especially the resident that are doing the procedure, where you should make the incision. Of course, there's always various options, and do not hesitate to ask the attending what exposure would you like to do and what incision should be made if you have any questions. So next, now that we know the external anatomy, we need to know what's inside, because the goal of any procedure is to expose the structure you need to remove or bypass without destructing the surrounding tissue. This is the goal of a surgical exposure. So you have to have some knowledge about the bone within the operative field, if there are any, the muscles, the arterial and venous structure, the lymphatics. I mean, you can't bag this. I don't think that's important, especially for vascular surgery, unless we talk about the thoracic duct, which actually is very important when you do supraclavicular dissection. But anyway, and the viscera. That's, the solid organs and the small bowel. So when you read or you look at an anatomy text, those are the important, you know what I forgot? The nerves. Probably one of the most important thing. Sorry. So when you look at an anatomy text, pay attention to what is present within the field. And in order to know that, unfortunately, again, you have to do some reading. And I don't know what texts you have. Those are the one I would recommend for vascular surgery. This is definitely the number one. And I think if you look at this beautiful illustration, very easy and quick read. This can be done 15 minutes before the surgical intervention, and if you have basic knowledge, you should be able to retain this. This is, I think, one of the most perfect book on exposure I have ever seen. This is what I would recommend for general surgery. I just looked it up on Google, and their preview seems very good, so I would recommend that. But maybe the chief resident have a better text to recommend. So when you read, you just keep those things in mind: where the incision is being made, what are the external landmarks, what are the structures within the operative fields, and how do you go step by step through the operative approach. And so this is the basic anatomic knowledge you need. So the second thing would be the indication. Why are we doing this procedure? And what are the options? So most commonly, the three options are conservative, and this includes medical therapy only, and I would include here radiologic procedure. Then it's minimally invasive, so those are all the laparoscopic procedure, or laparoscopic or endovascular, if you are interested. And finally, conventional therapy, or what we call open procedure. So we'll have some understanding on why we're doing this procedure on this patient, what could be the potential option, if any, for the patient. Next, complications. I think you should definitely be aware of what complications may occur with the specific procedure. And I think those can be divided again in three categories. First, the one related directly to patient disease and anesthesia. Two, the complication associated with any type of surgical procedure. And three, what are the complications specifically related to the procedure. So when it comes to anesthesia and general surgical complication, I think you can divide them into pulmonary complication, cardiac, GI, wounds. Where the wound is located is important. For example, a groin incision has a higher complication rate than a facial incision or a upper abdominal incision. And a complication associated with indwelling catheters. So that's A-lines, Foley catheter, IVs, central access, and so on. And those are essentially the general complication associated with any surgical intervention. Of course, don't forget airway, the patient is being intubated. and for the pulmonary complication, atelectasis, pneumonia, cardiac, obviously the most common complication would be myocardial infarction. And then the one specifically related to the procedure, and I think they can be divided into traumatic. So this would be an injury caused at the time of exposure using a retractor. They can be also technical. For example, you can injure the hypoglossal nerve when you do a carotid endarterectomy, or the vagus. And complication inherent to the procedure, and that would be, again, if we do a carotid endarterectomy, that would be stroke, or an aortic aneurysm, bleeding, embolization, and so on. And I think that's pretty much summarize what you need to do. So an example, I'd say I picked up carotid endarterectomy. So again, read with a purpose. And I don't know what text is available to you, but just look for this information and just retain that information. So what is the goal of the procedure? The goal is to expose the vessel, pretty straightforward, remove the plaque and close the vessel safely. So what anatomy do I need to know? So again, body landmark, where is my incision, and what are the structure in the field. So I'm going to do a quick drawing for you here. You have the ear, angle of the jaw, the cranium, well, that's an alien cranium, mastoid process, the neck, sternal notch is here, you have the shoulder here, so I know where the sternal notch is, I know where the xiphoid process is, I know where the sternocleidomastoid is, and then I can draw my incision. Alright, what are the structure in the field? At the level of the skin, there's an posterior auricular nerve here that is superficial and supply the ear. There's the external jugular vein, that may be in my field, across here, and that's essentially it for the superficial structure. So when we make our incision, the sternocleidomastoid is retracted. Imagine this is the left side of the patient, and I'm left, the first structure I will see is a jugular vein with the facial vein here. So the facial vein is important because under it, I know I will ligate it, and under it is usually the carotid bifurcation. And I know that's where the plaque is. So the vagus nerve is usually posterior to it. The hypoglossal nerve is in the field. It can be at different level. And there's the ansa cervicalis that usually can be divided with impunity. So I would say another nerve structure to be aware of would be the glossopharyngeal nerve, which is under the digastric. Let's see, that's about it as far as anatomy is concerned. So that would be the sternocleidomastoid. You have the mastoid process, the omohyoid below. Jugular vein, facial vein, carotid. I think that's about it. So, indication for the procedure. So why are we doing this intervention for this patient? So this is, for example, a asymptomatic carotid stenosis greater than 80%, or symptomatic carotid greater than 70%. Those are the indication for carotid endarterectomy, the common one anyway. The option would be conservative management, so aspirin and Plavix, stenting, which would be the minimally invasive procedure, or carotid endarterectomy. So why did we choose this procedure in this patient? Well, there is a couple trial, ACAS and NASCET, that showed that there's a benefit of carotid endarterectomy over medical therapy in this patient population. Stenting definitely an option, but why aren't we stenting this patient? Well, we know that stenting has an increased neurological event rate despite a slight decrease in cardiac event rate, and usually is reserved for high-risk patients. So if this patient is low risk, that is why he's undergoing carotid endarterectomy. Finally, the common complication associated with the procedure: stroke, hematoma, cranial nerve injury, the most common. You know your anatomy, so that would be vagus, hypoglossal nerve, or glossopharyngeal nerve. Then the complication inherent to the anesthesia: airway. The patient is being intubated. You're doing neck surgery, so they can develop edema, so upper airway complication. Or myocardial event. Approximately 60 to 75% of patients with carotid disease have associated coronary disease. So this is a very common complication, postoperative myocardial infarction, in this patient population. So that's it. This is how you should approach the operating room. And again, I think it's important to now that you know what you have to what your knowledge should be, I think it'll be easier for you to get prepared. Anyway, I hope this helps. Let me know if you have any issues. Thank you.